Trauma Facility Designation. The Montana Trauma System is a voluntary, inclusive system designed to provide an organized, pre-planned response to the trauma patient, helping assure both optimal patient care and the most efficient use of limited health resources. Why should we designate if it's voluntary? Designation can increase revenues and save money. Once designation has been achieved, you can bill for trauma team activations that have EMS pre-notification and meet pre-established criteria. System efficiencies will lead to decreased complications, length of stay, and overall costs. Decreased complications and things falling through the cracks will lead to more satisfied patients and families, which decreases the likelihood of lawsuits. Other departments and programs will emulate trauma performance improvement and system efficiencies, improving the bottom line for the whole hospital. What is the difference between designation and verification? For verification, an evaluation process needs to be done by the American College of Surgeons Committee on Trauma, ACS-COT, to evaluate and improve trauma care. The ACS does not designate trauma centers. Instead, it verifies the presence of the resources listed in Resources for Optimal Care of the Injured Patient. These include commitment, readiness, resources, policies, patient care, and performance improvement. Verification by ACS is a voluntary process paid for by the facility to assist hospitals in the evaluation and improvement of trauma care and provide objective external review of the facility's capability and performance. American College of Surgeons Trauma Center verification process is highly encouraged for Level 2 and 3 trauma centers. The procedure includes submission of the ACS pre-review questionnaire to the state as well as the ACS. State representatives will participate in a parallel site visit in collaboration with the ACS surgeon reviewers. This facility then provides the state with a copy of the letter indicating ACS verification status when received. This letter, along with a report by the state representatives, will be submitted to the designation subcommittee of the State Trauma Care Committee, and they will make recommendations to EMS and Trauma Systems section regarding state designation. Designation in Montana is a process outlined and developed at a state or local level. It is a geopolitical process empowered by the authority of Montana state government to designate trauma facilities. The Montana designation process was based on the national verification process through the American College of Surgeons, ACS. The ACS Committee of Trauma has provided leadership in providing optimal care to the injured patient since 1922. The state identifies unique criteria by which to categorize trauma centers. These categories may vary from state to state and are typically outlined through legislative or regulatory authority. ACS defines 5 levels of facility, but there is no Level 1 trauma center in Montana. The 4 levels of trauma facility designation are defined in Montana. These 4 levels represent levels of available resources and capabilities. The 4 levels are defined through the Montana Facility Resource Criteria, describing essential or desirable characteristics within trauma program components for each level of trauma facility. You have regional trauma centers, area trauma hospitals, community trauma hospitals, and trauma receiving facilities. A regional trauma center, or Level 2 trauma center, is able to initiate definitive care for all injured patients. They are the lead trauma facility to other hospitals in the service area. Elements of a Level 2 trauma center include 24-hour coverage by general surgeons, as well as coverage by the specialties of orthopedic surgery, neurosurgery, anesthesiology, emergency medicine, radiology, and critical care. They offer professional and community education and are a resource for Level 3, 4, and 5 trauma centers. A Level 2 trauma center incorporates a comprehensive performance improvement program, and they are involved with prevention efforts and must have an active outreach program for its referring communities. An area trauma hospital, or Level 3 trauma center, has demonstrated an ability to provide initial resuscitation and immediate operative intervention to control hemorrhage and multi-system trauma care. Elements of a Level 3 trauma center includes 24-hour coverage by emergency medicine physicians and the prompt availability of general surgeons and anesthesia providers. They incorporate a comprehensive performance improvement program, and they have developed transfer agreements for patients requiring more comprehensive care at a Level 1 or Level 2 trauma center. A community trauma center, or Level 4 trauma center, has demonstrated an ability to provide advanced trauma life support prior to transfer of patients to a higher level trauma center. It provides evaluation, stabilization, and diagnostic capabilities for injured patients. Elements of community trauma centers include basic emergency department facilities to implement ATLS protocols and 24-hour laboratory coverage. Nurse and provider are available upon patient arrival. They may provide surgery and critical care services if available. They develop transfer agreements for patients requiring more comprehensive care at a Level 1 or Level 2 trauma center, and they incorporate a comprehensive performance improvement program. A trauma receiving facility, or Level 5, provides initial evaluation, stabilization, and diagnostic capabilities and prepares patients for transfer to higher levels of care. Elements of a trauma receiving facility include basic emergency department facilities to implement ATLS protocols, a nurse and provider available upon patient arrival, after-hours activation protocols if facility is not open 24 hours a day, and they have developed transfer agreements for patients requiring more comprehensive care at a Level 1 through 3 trauma center. Montana Trauma Facility Designation Criteria defines the essential and desired criteria required for designation at a given level. The most recent version was effective in 2015. Each facility needs to look at the specific essential and/or desirable criteria required for the particular level of designation being sought. The Department of Public Health and Human Services determines the final designation of the facility based on consideration of the application, the recommendations of the site review team, and the recommendations of the State Trauma Care Committee Designation Subcommittee, and will notify the applicant of its decision in writing within 30 days after receiving the recommendation from the Designation Subcommittee. One of the following actions may be taken by the EMS and Trauma Systems section of the Department of Public Health and Human Services. 1. Designate the applicant as a designated trauma facility for a full 3 years. 2. Issue a provisional designation if there are deficiencies noted but the facility is substantially compliant with the resource criteria and any deficiencies will not have an immediate detrimental impact on trauma patient care. 3. Designate trauma facility at a different level from that for which the applicant facility applied, provided that the facility meets all the requirements of the alternative trauma facility designation level and the facility agrees to be designated at the alternative level of designation. Or 4, deny any trauma facility designation if there is a substantial noncompliance with the requirements, or the deficiencies are fundamental or may have an immediate detrimental impact on trauma patient care. Note that for option 2, a provisional designation is usually only granted for a period not over 1 year. At the end of the year, the facility will undergo a focused review to determine what the facility has accomplished towards meeting the recommendations made during the initial site review and how weaknesses and deficiencies have been addressed. Review the Montana Trauma Facility Designation Criteria, which detail the requirements and desired assets for trauma facility designation at the 4 levels available. Confer with facility staff and medical providers to determine the level your facility will commit to. The Facility Designation Criteria document lists trauma program components by level of facility within the 4 columns provided. Preparing for a trauma site review, timeline and checklist. Preparing for a trauma site review, timeline and checklist is an all-encompassing tool that follows a timeline and provides a checklist to ensure you have completed all the necessary components to be successful at designation. Complete the pre-review questionnaire, or PRQ, for desired level of designation obtained at the EMSTS website. The applicant indicates the level of designation being sought by completing the facility level specific application. Mail 3 copies of the completed application with requested documentation attached to the Montana EMS and Trauma section of Department of Public Health and Human Services. The application will be reviewed for completeness, and you'll be notified if additional or missing information needs to be sent in for the application. The state will begin selection of a site survey team and schedule a mutually agreeable date for your site review. The site review assesses your facility's commitment, readiness, resources, policies, patient care, and performance improvement. The team members involved will include a trauma surgeon reviewer, trauma coordinator reviewer, and EMS trauma system representatives. The next few slides will go through PRQ attachments mentioned earlier that are sent to DPHHS. Starting here, we have resolutions supporting the trauma program and an organizational chart. There must be defined authority and accountability for the trauma program within a well-defined organizational structure. While facility structures differ, without defined lines of authority for trauma program processes, no truly integrated program is recognizable. Additional attachments are the trauma flow sheet, trauma team information, and inter-facility transfer information. Next, you will need the Trauma Medical Director job description. The TMD, depending on level of facility, may be either a board-certified surgeon, board-certified ED physician, board-certified physician, or a mid-level provider. All providers must have a special interest in trauma care and lead the multidisciplinary activities of the trauma program. The TMD has the authority to affect all aspects of trauma care, including oversight of clinical trauma patient care, recommending trauma service privileges, development of clinical care guidelines, coordinating PI, correcting deficiencies in trauma care, and verification of continuing trauma education. Not surprisingly, you will also need the trauma coordinator job description. The TC, depending on level of facility, may be either a full-time dedicated RN, a part-time RN, or an alternatively qualified allied health professional. All must work in concert with the TMD. Make sure you are ready for the site review, which happens next. Follow preparing for a trauma site review timeline and checklist. Take care preparing the PRQ and attach all extra documentation. Identify representatives that are needed at the opening meeting. Prepare a program overview presentation. Have staff prepared for a facility tour. Medical record and PI preparation needs to be done. The trauma registrar should be present. TC and TMD are encouraged to participate in the entire review, which takes approximately 5 to 6 hours. The site review will begin with an opening meeting with the individuals most involved in the trauma program, including the trauma medical director and trauma coordinator, representatives of EMS services that transport patients to your facility, hospital administration, director of nursing, interested physicians and mid-level providers, and department managers or key personnel from the emergency department, radiology, laboratory and blood bank, quality and performance improvement, and disaster preparedness. This meeting allows an opportunity for the reviewers to provide an overview of the designation process, ask questions regarding the designation application, and interview EMS personnel. It is encouraged that this meeting begins with a short presentation by facility personnel, usually the trauma coordinator, to provide an overview of the community, facility resources, and trauma program development, including injury prevention. Please provide a written copy of the presentation to each of the reviewers. The reviewers will then tour the facility, beginning in the location where the trauma patient usually enters the facility through the ambulance entrance, then to the emergency department, radiology, and the laboratory and blood bank. Ideally, this tour will be guided by the trauma medical director and trauma coordinator. Next, the site reviewers will review the medical records for trauma patients meeting trauma registry criteria for the year identified in the application. Once the medical record is read, the reviewer would like to see the corresponding completed trauma registry abstract form and performance improvement activities for that patient, including trauma committee minutes when the case was reviewed. Any outcomes from performance improvement, such as education provided or guideline development, should be included. Optimally, the performance improvement documentation is copied and accompanies each separate trauma medical record. Any trauma policies or guidelines, transfer agreements, trauma education of medical and nursing staff, physician call schedules, and injury prevention will be reviewed at this time. The trauma coordinator and trauma medical director should be available for questions. Following a short meeting where findings of the survey are discussed, the site review team will make a verbal report of its findings through an exit interview prior to leaving the facility. They will complete a confidential performance improvement report for your facility indicating the identified strengths, weaknesses, and recommendations for improvement that will be provided to your facility for the purpose of performance improvement. The site surveyor team also provides a written summary of their findings and recommendations for designation to the Department of Public Health and Human Services for the purpose of determining trauma facility designation. The department shall review the site review team report and forward a copy to the designation subcommittee at the next quarterly State Trauma Care Committee meeting. This group will make a recommendation to the department regarding the trauma designation of the applicant facility. Chart review preparation. Paper copies should be available of the following for each chart: EMS trip sheet, trauma flow sheet, all ED documentation, provider's dictation, history and physical, discharge summary transfer, follow-up from receiving facilities, performance improvement associated with each case, and peer review, if applicable, with each case. Access to computer charts should also be available with personnel to navigate the system. Other documents that will be reviewed are trauma committee meeting minutes, injury prevention activities, disaster drills and exercises, performance improvement projects, peer review minutes, education documentation for staff, EMS outreach and participation with your program, policies, protocols, and guidelines. And do these policies make sense for the level of facility? Are the policies clear and accessible so locums, doctor, or travel nurse could read and understand facility practice? Do the policies accurately reflect facility practice? You'll also look at physician call schedules. But wait, there's more. Additional documentation for review involves trauma system participation and disaster preparedness. The multidisciplinary trauma committee documents need to be reviewed next so that the reviewers know the following is occurring. Representatives from trauma-related services, including EMS. They meet regularly with written minutes that include attendance. Minutes should include only a summary of the cases, but detail on the ensuing discussion, what conclusions were reached and what is the plan for accomplishing recommended changes, and assess and correct trauma system process issues to optimize trauma patient care. Here is an example of meeting minutes with trauma performance improvement noted. Trauma peer review minutes will also be reviewed. Trauma peer review is the review of deaths, complications, and clinical care issues of seriously injured patients. This process is medical provider focused with participation of medical providers involved in trauma care. This should be a limited access forum, but the trauma coordinator must attend when trauma cases are reviewed. Documentation of the sessions should be written carefully, but should also include candid discussions. All performance improvement documentation should be clearly labeled Confidential Performance Improvement Peer Review. Injury prevention documentation is next, showing community assessment for community-based activities, data analysis done to target needs, the building of community partnerships, what programs and public education on trauma has been conducted, and the impact of program effectiveness. Staff involvement and education documentation shows who is on call or in-house and promptly available, monitors performance improvement, tracks trauma-related CME annually, records ATLS course completion, preferring current verification, and shows participation in trauma peer review. Nursing involvement and education documentation shows nursing coverage for immediate care of the trauma patient, if they ideally have planned for a minimum of 2 nurses with at least 1 RN, if they provide for continual monitoring of a patient from arrival to disposition from ED, and tracking the 6 hours of trauma-related education annually required. Clinical care protocols are reviewed too, which include the Montana Trauma Treatment Manual, trauma-specific facility clinical protocols, guidelines, and policies that are a byproduct of productive performance improvement, evidence-based medicine, which has become the standard of care, and clinical protocols ensuring that all the care provided is contemporary and consistent. Some examples include C-spine clearance and backboard removal, massive or rapid transfusion policy, and RSI protocol. Once all of this information is received, the next step is an exit interview or verbal report. This should include all the same persons present at the opening conference. The reviewers will give a verbal report of findings of the designation visit and put them into categories: deficiencies, strengths, weaknesses, opportunities for improvement, and recommendations. Reviewers will give their recommendation of designation outcome: full designation, provisional designation, or no designation. A final written report will be produced after the site visit. Recommendation of designation status will be forwarded to the Performance Improvement Committee of the State Trauma Care Committee to review and make the final determination of designation at their quarterly meeting. Final reports 1 narrative, and 1 PI checklist, letter of site visit outcome, and certificate will be sent out via certified mail to the CEO with copies to the TMD and TNC following STCC's meeting. Repeat this process every 3 years to maintain designation.